Welcome and thank you for joining us for this webinar presentation. We are the Homeland Defense and Security Information Analysis Center, or HDIAC, one of 3 IAC domains in the DoD Information Analysis Centers operating under the Defense Technical Information Center, DTIC, within the Office of the Undersecretary of Defense for Research and Engineering. Our informative webinar series highlights current and emerging research and technology developments. It presents an opportunity for accelerating the DoD's leverage of these advancements by increasing awareness and fostering technical collaboration. HDIAC serves as one of the premier information research partners and curators of technology advancements and trends for the Homeland Defense and Security community. As such, our organization supports those working in the Homeland Defense and Security domain of DoD research and engineering. We do so by helping navigate the vast landscape of scientific and technical information, allowing our customers to get a head start on their technical projects. With an understanding of the Homeland Defense and Security DoD research and engineering landscape, we provide research and analysis services. We help unlock access to information, knowledge, and best practices from government, industry, and academia to stimulate innovation, foster collaboration, and eliminate redundancy. We hope you enjoy this webinar presentation and that it serves as a catalyst for community collaboration and improved DoD Homeland Defense and Security research.
All right, welcome everybody. Good day to everyone. Thank you all for joining this webinar presentation. So along with our new video, we're going to have a little bit of a new format to this one. As I will be presenting a panel discussion on the impacts of infectious diseases on the U.S. military, going over some lessons learned from COVID-19 and what that informs us going forward with other infectious diseases as they emerge. Before we get started, I'll note a few administrative items. One, all participants are muted. Please feel free to use the chat box to the left-hand side of your screen to chat with the presenters and we'll try to monitor that as best we can. But ultimately, if you'd like to ask a question for the Q&A session at the end, please use the Q&A box in the top center of your screen. It's a little chat bubble right next to the emoji that you see up there. So use that to submit Q&A, and at the end of the webinar, we'll go over the Q&A. But with that, I'll also point out that this webinar will be recorded. So if you know somebody that's missed it or you want to come back to it, it will be on our YouTube channel. Just you can go back to our website at hdiac.org/webinars. Within the next 24 to 48 hours, it should be posted up there, and you can go to the YouTube recording from there, as well as you could go there also if you're dialed in on the phone, or you just want a copy of the slides, or I'm sorry, we don't have slides for this presentation. I'm reading from my script, and there I am, tripped over it already. So with that, I will go ahead and introduce our panelists for today. So our first panelist is Dr. Rodney Cauldron. He is a physician board certified in preventive medicine and public health. He retired as a colonel in the Army Medical Corps in June 2021. He has worked in emerging infectious disease surveillance and response, as well as infectious disease epidemiology. He served in the U.S., Korea, Kenya, Thailand, Iraq, and Germany. Key assignments include the Chief of Disease Epidemiology at Army Public Health Center and the Public Health Emergency Officer for U.S. Army Europe and Africa. Additionally, he is the Associate Professor of Preventive Medicine at the Uniformed Services. Sorry, help me out here, Rodney. That is USUHS.
Yeah, USUS, Uniformed Services University of the Health Sciences.
There we go.
Thank you very much for the introduction, and thank you everyone for attending.
All right, thank you. Next, we have Dr. John Sandin of Quantum Consultant. He is a senior medical and CBERN WMD advisor with over 20 years of domestic and international experiences. He received his PhD and a second doctorate degree in the health sciences from Nova Southeastern University. He also has a clinical laboratory specialization in medical technology from George Washington University. John has served in multiple health security and CBERN WMD non-proliferation roles while deployed to Africa, Asia, and the Middle East. His research interests are in health security, emerging medical therapies, on and off the battlefield, CBRN preparedness, and WMD nonproliferation. John, welcome.
Hey, thanks, John, and thanks, HDIAC, for this opportunity.
Absolutely. And finally, that we round this out with Mr. Gregory Nichols. He has over 20 years experience supporting operational and research activities in healthcare, occupational environmental health, and homeland defense security. He currently serves as a subject matter expert for the Homeland Defense Security Information Analysis Center. He is primarily known for his work in evaluating risk and applications of emerging technologies, especially nanotechnology, in public health, national security, and defense. And he has published and presented extensively on this topic. He holds a Master's of Public Health degree in Health Planning and Administration from the University of Tennessee and holds certifications in public health, safety, and quality. He is a U.S. Navy veteran, having served as a hospital corpsman. Greg, welcome aboard.
Thanks, John. Happy to be here.
Great to have you. And I am John Clements. I am the technical lead for HDIAC. And I will, without further ado, I'll go ahead and get started with the questions for the panelists. So first, I'd like to toss the first one over to Dr. Rodney Cauldron. So Dr. Cauldron, in the early days of the COVID-19 pandemic, you were serving in a public health capacity at U.S. Army Europe and Africa. Many will recall that the pandemic impacted Europe very hard, very early. What were some of the immediate hurdles you had to face to protect the force?
Sure. So COVID rapidly jumped from Asia to southern Italy, actually northern Italy, but southern Europe was the first place we saw it arrive in Europe. And for those of you who remember, we went through a period of time where individuals my age, 50 and up, in Italy would be denied a ventilator because they simply didn't have enough. They had to go into true crisis triage. The scenes were heartbreaking. It then jumped to Spain, and we all heard the stories of dozens of individuals dying in nursing homes as the staff abandoned them. The Army wasn't quite that far behind the eight ball, if you will, but it certainly was not prepared for what happened in the way we would have liked. We had to backfill from Germany respiratory care teams to Italy because they didn't have access to ventilators or to a sufficient number of individuals who could intubate and support folks. And there was simply a lack of guidance. At this time, the CDC had come out with no guidance other than saying we're watching it carefully. Army Public Health Center still didn't have guidance, and this was largely because it was such a new thing. Nobody really knew what to expect. So the infectious disease specialists and I essentially had to make up recommendations by the seat of our pants, looking at the very scant data that was coming out of Asia, in particular our forces in Korea. It was just the issue of being about 2 to 4 weeks ahead of the outbreak in the United States. And that really was enough time that folks in the continental U.S. were not necessarily tracking the severity or the urgency of it. So it really did lead to a lot of scrambling on our part, but a lot of great lessons learned that we were able to pass on to others. Over.
Great, thank you very much. So, what would you say? How do we protect the force and maintain readiness at the same time?
It's a difficult challenge, and it really is a balance. Depending on the agent you're protecting it from, the countermeasures are different, of course. But airborne diseases are really the hardest one to protect from. And you have the horns of a dilemma, because if you have enough people getting sick, that degrades your force and the readiness of the force, particularly if you have folks dying, not only from morbidity and mortality, but just the demoralization of that. On the other hand, if you don't train, skills degrade. And our mission is to project power. And so this was a very difficult dilemma that had to be answered really by the commanders because they're ultimately in charge. They're the chief public health official for their unit. They had to determine how aggressively they could train in collective training, small groups, up to larger groups. And we as public health people had to advise them the safest ways to do that. And also overseas, where I was, the additional layer of having to abide by the host nation's laws. It created significant tension at times between our host nation politicians who are charged with the public health safety of their populations and our commanders and our activities. At the end of the day, being in the military is not a risk-free occupation, and so risks do have to be taken. And ultimately, we all knew that if the balloon went up and somebody had to deploy a unit for kinetic or anything just short of kinetic operations, that all of the rest of the things we were doing would essentially have to be set aside because mission first. People always, of course, but mission comes first. So these were things we had to plan for. These were the tensions that we were facing.
All right. So one of the things you have mentioned to me previously was bringing back teams at the unit level that would have a public health role. Can you kind of elaborate on that suggestion of yours?
Sure. So by regulation, specifically AR 350-1, Army Training and Leadership, every deploying unit is required to have 2 trained field sanitation teams, and there are 2-person teams, so they need 2 2-person teams. Team leader has to be an NCO, and they have to undergo 40 hours of training to be certified. While this is the regulation, I have very rarely seen it enacted. And this, by the way, is done at the company level. So every company needs to designate 4 people for this training and these teams. I have never seen it aggressively used. When I was in Korea, the only way I was able to get battalions to have their teams trained up was to put a red, yellow, green stoplight on my briefing slide for the CG, and then suddenly it became very important to everyone. But inherently, prevention is often a neglected task, and we're all guilty of this. The tyranny of the immediate often takes precedence over preparing for the future. But also there's a belief that this should be handled by medical, whether it be a combat medic who does not have the training unless they go to the 40-hour course to do the public health tasks required of the unit sanitation team. There's also a belief that perhaps the preventive medicine assets at echelons above should be doing all of this, and there simply isn't enough personnel in these higher echelons. They're there to train the unit sanitation teams and to do quality assurance. Finally, if they do have a team, the NCO leader tends to be an E5, and it's somebody often that the commander feels that they can do without on other missions, to put it bluntly. The units really need a senior NCO to either lead the team or maybe more time effectively serve as a public health advisor, somebody with the rank to enforce the recommendations of this field sanitation team, which otherwise would be just far too easy to blow off by the soldiers. Over.
Thank you. Finally, my final question directly to you, Elise. What kind of training would you like all service members to receive to increase public health readiness and awareness?
So that would fall into 2 general categories, and we'll probably get into the misinformation, disinformation portion of that later. So I'll set that aside, other than to say, we need to be better about teaching people how to recognize disinformation. More on the technical side, we need to instill in soldiers the ethic and the practice of um, public health discipline. It often can be uncomfortable, having to wear long sleeves in mosquito areas, which tend to be hot, would be one example. Um, Changing socks frequently enough to keep your feet from breaking down can be time consuming and can be a pain, but if you end up with trench foot, you're going to wish you did it. Sleep discipline is another biggie. Commanders, NCOs, and even soldiers push themselves um, to try and go as long as possible without sleep to maximize their work output during deployments and training. And time and time again, we've learned that lack of sleep leads to poor performance and decreased unit and individual health outcomes. There's an excellent Army training, It's training circular on field sanitation, and it really should be required reading at basic training and at all stages of professional medical education, because it really is something that every soldier needs to be aware of, every commander needs to be aware of. Public health starts with the person; it doesn't start with anybody higher up than that. We can only recommend people actually have to discipline themselves. Over.
Great, thank you. So next, I will turn to Dr. John Sandin. You have responded to multiple outbreaks in different areas of the world. What are some of the notable similarities and differences you've seen between different outbreaks, and what have you learned from that?
Yeah, thanks, John. So as far as similarities and differences, I would say through every outbreak I've worked in, there's constantly been misinformation, disinformation that Rodney had discussed earlier, but specifically non-approved either technologies or medicinal usage. It can range from therapies such as sitting in a wet sauna to treat COVID, to drinking certain types of alcohol to prevent Ebola or to actually cure Ebola, to all different types of things, or certain skin creams, or just you name it. It's been, we've heard about it, or just non-approved technologies and medicines. And when that happens, that creates not only an issue for the community that you're working in, but also distrust, because among healthcare workers and public health officials, because people are holding on to hope. They want something that is a quick fix, that is proven. And if there's not something that is readily available, they often will search for something that might provide that therapy. And some of these therapies do provide maybe some relief to symptoms, but they don't necessarily cure. And that's the challenge. And so and then along with the misinformation, disinformation is also some of the proven countermeasures, let's say, such as vaccines. The misconception is as soon as you take let's say the vaccine, you won't get that disease element. And obviously there's a lag time between the vaccine and the actual the therapeutic value of that. And sometimes that takes time. It can take a week to 2 weeks, depending on what the vaccine is for. And it's just misunderstanding that you're instantly cured. And just how do you talk around that? What's the risk communication? What's the community engagement involved in that?
Thank you. Now, so how do these similarities and differences inform how the U.S. military specifically handles pandemics?
Yeah, and that's a great question. So the military uses an evidence-based approach. They don't use unapproved therapies. As you noticed, they waited for the vaccine for it to be required. They waited for the FDA, not just the emergency use authorization, which is not an approval, but the authorized use of it. They actually waited until the approval of the COVID vaccine until it was required, and then they gave a certain amount of time for the service members to receive that vaccine. So the military uses an evidence-based approach. They look at best practices and different types of techniques to ensure that any type of medical countermeasures that they're instilling is proven, is safe and effective.
Okay, so you've seen the way that different cultures respond to pandemics. Does that tell you anything about pandemic response in general?
Yeah, so yeah, there's not a there's what the textbook says, but then there's obviously what policies instill. That's what governments either recommend or imply, and then at the end of the day, it's the individuals that adhere to those guidelines and regulations. So we saw with COVID, there was a mix of everything. Just in the United States, it could vary state by state, city by city. And some cultures, some countries would go into full lockdown for months and months at a time, and come out of lockdown, and then their numbers would shoot up. So it varies completely culture by culture. So there isn't necessarily one size fits all. What's important is to ensure that your public is informed, that they understand the worst or the risk versus what type of opportunities there are as far as if you were to go out in a crowd, this is what your risk is. This is what you're going to be potentially exposed to, so that individuals can make informed decisions is very important. So effective communication is key, no matter what, throughout any culture.
And you have a unique background in both the military role as well as other government agencies roles. So what does the whole of government approach look like to you?
Yeah, to me, I would say it's not just a government approach. I like to look at it as a public-private partnership. So what that means is, government just it doesn't work to just say, here's some guidelines, and then no one follows it. Or the private industry says, I'm going to require everyone in my office space to wear masks without any type of guidelines. It's really what's called the P3, the private-public partnership, and those entities working together can help create more of a safer environment, more of an informed environment, so that the individuals, whether it's in an office space, whether it's in a shopping center, or any type of, let's say, airplane, depending on the situation, they're able to make an informed decision using evidence-based practice to really help the end user, which is either the stakeholder, the individual, or the persons that they're supporting, which is that private-public partnership to really help society through that pandemic. And so I don't think it's just the government. It really is a collection of the civilization to really get through a pandemic successfully.
Great. Well, thank you very much. And
Sure.
so what I'll do now is I'll turn to Gregory Nichols. So you're a person who stays abreast of technological developments within multiple disciplines. What technologies are being developed or have recently been developed that you think will be game changers for pandemic preparedness for the military?
Yeah, thanks for asking, John. I think that's a really good question. We've seen kind of like a launch party for a lot of technologies. I think during this pandemic, it was an opportunity for some areas to shine. And I've got 6 key areas where I think technology directly or kind of in the spirit of technology development really came of age. The first is around the wastewater surveillance. We really saw that as a game changer, I think. It's kind of been something that's been around for a while, but it really was useful and implemented, I think, more than any other time during COVID. And now, we see the CDC has a national wastewater surveillance system. So I think that's going to be a key part of pandemic and epidemic surveillance going forward. Another key area, I think, revolves around this avenue of additive manufacturing and advanced materials. We saw when there were supply chain shortages that it was difficult to get personal protective equipment. We saw people kind of scramble to try to figure out how we could get things more on demand. And one of the areas that really grew up was people were 3D printing things like face shields, right? For healthcare providers. Another thing was we figured out that we could use one ventilator for multiple patients, but we needed splitters for the tubing, but there weren't enough splitters. So people figured out a way to 3D print the Y splitters to make that happen. So that was pretty innovative. I think we're going to see more things like that. Some advanced material development too, especially when you look at like N95 respirators, trying to find materials that could be reused or sterilized so we don't get into that single use problem like we had a lot with some of the masks. I think the third area that really kind of shined was artificial intelligence, especially using machine learning and drug discovery and vaccine development. It's really interesting. We've got so much data now that we've collected on all these existing compounds and things that are in pipelines that we were able to go through and have some of these different neural networks try to figure out what sorts of existing things may actually be um, efficient against fighting COVID or developing a vaccine. And Rare and NIH did some work on this, and there was also some work at Oak Ridge National Laboratory looking at this. And so I think going forward, that's going to be a key piece of being prepared for the next pandemic. The fourth area really, it's two technologies that revolve around the vaccines themselves. One is the mRNA platform. I think that was a game changer. This is the fastest that we've ever developed a vaccine that was effective, as far as I know, especially against the coronavirus. It's usually not a viral family that's easy to develop a vaccine for, but we were able to do it using the Moderna and the Pfizer BioNTech platforms. And then related to that was the lipid nanoparticles that were used as the vehicle, right, the drug delivery system. Lipid nanoparticles have been researched a lot in other areas like chemotherapy and neurology, but kind of exploring that more as to how we can use those particles to more effectively deliver vaccines and improve like targeted medicine and things like that. The fifth one is kind of a very generic category, but the telemedicine and telehealth platforms, they kind of started out like they've been around for a while, but it started off as kind of like a Zoom or a team meeting, right? Very kind of one on one. But they've really gotten to evolve, and the Army has a really good platform called Advisor, where you can send text messages and emails, and you can have providers respond in real time to people out in the field, and it's used a lot in battlefield medicine. So, kind of having a more mature or maturing of some of those platforms, I think, is going to be important, and we've already seen a lot of that come of age. And then finally, there's this other kind of very large generic area, but it really revolves around the subclinical and preclinical diagnostics. This has always been like a holy grail of medicine and epidemiology, right? Trying to identify who is sick before they exhibit symptoms or who is probably going to be sick. I think it's really important with COVID because COVID is one of those illnesses where people have become infectious before they actually show symptoms, right? Which is a nightmare for public health tracking and surveillance and contact tracing. So anything that we could do to try to figure out who may be sick or about to get sick so we can look at isolation and quarantine. There was a lot of interesting things being done with like wearable technologies, trying to identify like slight temperature changes and maybe elevations and blood pressure and heart rate, and trying to look at 90% of the time patients who have these things go on to develop COVID, right? And the Army actually has done a lot of work looking at this as well. So I think that's going to be an area of research and development that's going to be very important going forward.
Wow, great. Thank you very much. So, what technology gaps do you think are still out there that we should be focusing on now?
Yeah, and this one's always kind of controversial, right? Because it comes down to like money and time and resources, and everybody has their own priorities. But I have four areas that I think are important. A couple are just very broad areas in general, and then there's a couple of technology specific ones. Um, I think looking at that whole realm of translational research, translational science is really important. Trying to take all of the things that we have in R&D pipelines and get them out to the real world. that's really hard sometimes, right? Because you've got need issues and funding issues and distribution issues. But I think during the COVID-19 pandemic, we saw a lot of really good use of technologies that were developed, but maybe not at a high technology readiness level and maybe not on the market yet, that kind of got shoved out. I think DARPA did a really good job of this. DARPA's got a ton of programs and a ton of technologies that they funded over the past several years, and they were able to get a lot of things out and into use, especially in DoD realms, early on in the pandemic. So I think looking at how do we do that better is going to be important. Another one we mentioned it. John and Roddy talked about this, but the disinformation and misinformation, right? So social media played a huge part of this disaster response, this pandemic, right? And there was a lot of misinformation out there, some accidental, some intentional. Social media has played a big role in disaster response for about the past decade, so I don't see that going away or changing. It's very useful for certain situations. So I think it's going to be really important as to how we come up with some good ways to mitigate and put some checks and balances on that information that's flying around out there. Another area, and this is very specific, I think, mainly to lipid nanoparticles and maybe some of the other therapies that are kind of more advanced. But looking at long-term biokinetic modeling, we we really don't have any long-term appreciation for what happens to lipid nanoparticles in the body. What do they do? How they affect people? Short term, we've got a good idea, but what do we need to look at to make sure that these technologies and these therapeutics will be safe and effective so that we can actually make this technology beneficial, right? We don't want to have anything fall flat on its face early out because we fail to address some of these health and safety concerns. And then finally, I think just another broad area, how do we use technologies to strengthen our supply chains? And I'm really thinking about 3D printing and autonomous systems. How do we use that better? How do we develop and deliver like resources on demand and on location? I think that was a big challenge. We had a lot of stuff, but when people are sick and they can't fly the planes, they can't use the trains, they can't get ships across, right? And things are stuck in ports and warehouses. Just it's sitting there, it's being wasted, right? So how do we figure out a better way to either print things on demand or have things pre-staged or have drones deliver things and people can't get there because they're sick, right? So I think that's going to be an important thing. And we had a lot of that kind of start to develop. So it'll be interesting to see where that whole area goes.
Great. And so, where do you think we will be or moving 5 years from now? Then,
Well, hopefully we'll adopt and implement, a lot of the policies that are based off of lessons learned from this pandemic. So it's one of those things, we saw a lot of this after September 11th, where there was a lot of money and funding put into disaster preparedness and broad preparedness, and everybody was like all gung ho about it. And then after a while, nothing happened, and that kind of fizzled. So we'll see. Hopefully, we've kind of learned again. It's been 20 years since our last major event like that. So we'll see what happens with that. I think um, obviously SARS-CoV-2 is a virus, and so we've had a lot of developments and lessons learned and things based on a viral pandemic. So it'll be interesting to see what we've learned and how we can apply that to other types of pandemics, right? Looking at like bacterial infections like anthrax and tularemia and plague. So kind of being better prepared, not just for another pandemic that's viral based, but also other things out there. I think looking at how do we increase the diagnostic testing capacity and the contact tracing. This is kind of a sore spot early in the game, though, right? We had a lot of issues with developing a rapid test and getting it out. And interestingly, one of the biggest challenges was getting enough swabs to do the actual nasal test, right? We had tests, but we didn't have enough swabs. So, kind of things like that. How do we figure out a better way to develop a more robust testing capacity? Like there were other places, I think Taiwan did a great job in South Korea. So how do we maybe emulate some of those supply issues and kind of do a little bit better job using some of the technologies that were developed during this pandemic? And this one, I don't really have a better way to put this. So I have this idea of like, how do we automate public health? And what I mean is, like, how do we do as much as possible with technology on the front end before we actually have to get people involved, right? Because one of the challenges, anytime you're dealing with people, and I know public health is all about the public, but anytime you have to ask people to do things, it's really hard. And I think in occupational health and safety and industrial hygiene, we do a really good job of this with that hierarchy of controls, where you start with like engineering controls first, and then at the last moment you try to do administrative controls, and then you implement personal protective equipment. But that's really hard, so you try to stay away from that. So anything we can do to use sensors for early warning to try to identify like leading indicators of disease and things like that, I think is going to be really important. And then finally, I wrote this article getting ready for this, and I thought it was kind of interesting. But this pandemic really helped DoD understand some of the shortfalls that they had in preparing for like biowarfare. And so I think it's going to be really interesting to see how DoD and all the different component commands and services come together, take these lessons learned to say, hey, this is what we learned from this pandemic, but what happens if other related events happen? How can we be better prepared? And I think we're going to see hopefully a lot of that over the next several years.
Great, yeah, agreed, and thank you very much. So, I got a couple questions for the panel as a whole, and before we move to Q&A from the audience. So, one kind of touched on it a little bit when we were talking about misinformation and disinformation, but how can we improve messaging as it relates to pandemic preparedness?
So I'll jump in first with that. The key to it. Well, I'm not a public affairs officer, but from more of the public health side, the key to risk management, risk communications, is to have a clear, consistent message, and also to manage expectations up front. Say, look, and the CDC started off doing this quite well, and then this message got lost. But we're learning more and more every day. Our recommendations are going to change, and it doesn't mean that we didn't know what we were doing. It just means that we were learning as we went, just like everybody else. This was a new thing, and the fact that we discovered that masks actually do work, that was different than our initial advice. Um, and but we needed to lay the groundwork for that earlier on, rather than being so dogmatic about masks aren't going to work, or these recommendations are what we're going to have to do to protect it. So protect ourselves. So maybe introducing a little bit of preemptive humility in our conversations when we're making recommendations, without sounding so wishy-washy that people don't think we know what we're doing. And that argument, with the information we have at the moment, these are the recommendations we're giving. This is the very best we think you can do to protect yourself. Stay on that message, and repeat it, and make sure everybody, at least on the official side, is towing the same line, so that you have to get the information about changing recommendations out to leaders quickly. Otherwise, soldiers are going to be hearing one thing from their public health folks and something else from their leaders. Over.
John, did you have something to add?
Yeah, just to add to what Rodney's saying, also there's not just using a traditional, let's say, Army website to get that information out. As discussed, social media plays a huge impact. So if that's where a lot of our service members, or just the general public in general, is getting the information, we need to also provide that information on there in a safe and secure manner, obviously. But that needs to be provided as well through their official NCO channels or officer channels, through social media, through official websites, through multiple different platforms, and also targeted. There's not a one size fits all. What a National Guard soldier or unit in a particular state needs to know or understand might be different than another Guard unit in a different state, just based on upbringing, background, understanding, either appreciation for medicine or fear of the healthcare system just from past experiences. So know your audience, know your target, and be able to communicate effectively to them is so important on multiple different platforms is key.
Great, thank you. So, what are the priorities for the military to get right to be prepared for the next infectious disease threat, in your guys' opinion?
I'll jump in first if you guys don't mind, and then you can tell me I'm wrong or add to it. But I think one priority should be, like I mentioned earlier, that translational research. I think DoD has a ton of technologies and a ton of great partnerships. John talked about the public-private partnerships. There's a lot of good work that DoD does facilitating R&D. So I think continuing to look at that R&D pipeline, emphasizing translational research and understanding what do they currently have that can actually fulfill some real world needs. I think that's going to be one. Another one, you don't see this so much in the military. You see this a lot more with civilian agencies, but I think trying to figure out how do you address the waxing and waning support with public health funding and preparedness, right? It's kind of one of those things where when it's fresh and we're in the middle of it, everybody's like, yeah, let's take care of it. But then like the public has a short memory, right? And so things kind of fade. Military leaders sometimes don't keep things on the front burner like they should. So I think it's going to be important. How do we sustain not just the level of funding, but the interest to make sure that we're always prepared for something like this?
And oh, sorry, John, go ahead.
Go ahead.
Along with the translational research, which might in and of itself help solve the personnel problem. Time and time again, speaking to subject matter experts in my experiences in Europe, the DoD Inspector General report, talking at MTFs, we still have not seen the full fallout within our medical systems of the impact of being understaffed to respond to a major pandemic that not only taxed us to perform our organic missions, but also required us to send personnel to backfill civilian sectors, which then depleted us even further. This led to resignations, to burnout, to people working just way too many hours, which, as we know, is a safety hazard, which then leads to more people resigning and so on. It's that death spiral. It's one SME described it as like an insurance policy. We can pay more up front, and all preventive medicine, public health is like this, but we can pay more up front, and then the cost of what we're insuring against, whether in terms of money or poor outcomes, is mitigated more effectively. Or we can take the low cost, high deductible policy and bear the brunt of the wave when it hits us, and that's really what happened with COVID. We were drawing down. There were hiring freezes. Public health is always critically understaffed, at least in the Army, and it really was just devastating on our people. I watched public health nurse after public health nurse turn into school nurse, just in response to having to work 280 hours without a day off. So having sufficient personnel to weather the storm that is going to come again, because we have to remember, before COVID, we were all saying it's not a matter of if, it's a matter of when. And that's still true today. Just because we had our pandemic doesn't mean we're not going to have another one. Over.
Yeah, and just wanted to add, Rodney and Greg, before we can truly look forward, we have to look backwards. We have to look at that lessons learned approach. There's so much information that we can glean from that and basically readjust and redirect. And so, looking at best practices, looking at that lessons learned, looking at what went wrong and being able to adjust from there. when it just bringing this all together, what technologies are available, what training, what equipment, what type of personnel is key as we move forward, and to continue to expand on it. It's not if, it's when this is going to happen again, and we got to be better prepared into actual operationalizing. So these are all key for that.
Great. Well, thank you all very much. I do have a question from the audience that I'll go over. If anybody else would like to submit a question, again, there's a Q&A box at the top. Just saw another one come in. Q&A box in the top center of your screen, so please submit them there. I'll go ahead and put this up. It should show up on the screen. I'll read it out loud for those that are on the phone. From Sam Brower. Does our response to COVID-19 show the need for rapid access to broad-spectrum antivirals?
Yeah, one of the research needs that has been identified really is developing either broad-spectrum antivirals or preferably species agnostic antivirals, but also platforms that can be rapidly scaled up to address a different, a new novel virus. But certainly, if we had an antiviral on the shelf that would adequately treat the entire family of, say, coronaviruses or influenza viruses, while not the absolute holy grail, that would be pretty darn close to the holy grail of therapeutics. Over.
Great, thank you very much. That I'll move to the next question from Matthew Mendonca. Sorry if I'm butchering your last name there. What changes has the Navy made or should make to address the particular challenge of handling an outbreak of an infectious disease or even a biological warfare agent in the confined spaces of a ship?
That's a really good question. I kind of feel like the resident Navy man here. I should probably take a stab at that. So there's a really good RAND report that was published a year or two ago about this issue, about the Theodore Roosevelt and everything. So if you haven't seen that, I would check that out. I can get the information to John and we can get that to you, but I think that's worth reading. I think this is always an issue. The Navy historically has always faced a lot of challenges with disease, right? Just because you've got a bunch of people in a confined space traveling all over the world to unknown ports. So it's always been a challenge. I think they've always done a really good job. I don't know exactly what happened in this particular case. I just don't know enough about it to speak well and informed of it. But obviously, anytime you're in confined space with a whole bunch of people, you're looking at specific precautions to reduce the transmission of disease. I think this is where it becomes really important to have that diagnostic capability and trying to figure out who could be sick, and if you could do some preclinical stuff, that's even better. But just having good precautions in terms of like isolation, quarantine, um, all the stuff that we always tell people, right? About coughing and hand washing and all that stuff. If you've ever been on a ship, it's you do your best. I'll just say that. But anyway, I think there's a lot of things. One thing I didn't mention too. There's been a lot of research in like antimicrobial coatings. So there's a lot of ways I think you could use some engineering controls maybe on a ship to kind of do that. But I think a lot of it just comes down to administrative procedures.
Great, thank you. Thanks, Greg. Do you have one more question that came in from Julio A? Oh, John, go ahead. I'm sorry.
Yeah, I was going to answer this question, the new one.
Oh, okay. So, question is, how does the DoD and other government agencies plan to maintain balance of public trust and situational awareness?
Yeah, I'd like to take a step back on this question and just kind of look at it holistically. I think with our service members and family members, we need to better inform them how to basically filter and process information. There's so much noise out there. You you can get the answer to whatever you're looking for if you look for what, in the right area on the internet. And it's hard to tell what is factual, what is not. And I think as leaders, as just good supervisors, good leaders, good mentors, we need to really help with the ability to just filter and process information to understand what might be misleading, what might be that misinformation or that disinformation, so that you can be better informed, so that you can pick apart that difference, so that you don't have that distrust necessarily of the public official. And this isn't just for COVID or diseases. This is just for in general. I think we can do a better job from the leadership side on that.
Great. Just had another question pop in. This one from Al Brzezinski. Based on lessons learned from COVID-19, what measures can be taken to address the medical surge capacity challenge?
So a lot of this was addressed in the DoDIG report, and so it does come down to not only needing bodies, but to using the bodies we have more effectively. Greg mentioned contact tracing. We wanted to use EpiX, which is a CDC U.S. government developed software package that can help with questionnaires and standardizing the procedure for obtaining information from individuals so that we could better do the contact tracing. It took 6 months for us to get permission to put that program on our government systems, which meant it was too late. The pandemic had already hit us in the face, and everybody was developing homebrewed Excel spreadsheets or pen and paper sort of responses. This then means that 2 or 3 times as many people need to be involved in it because the system has no automation in it. Automated contact tracing programs did come out that would actually automate the telephone calls, checking up on people, a lot of these things. We simply could not get them onto our systems fast enough. We also need to be better at being more flexible with how we use people. I can speak to Landstuhl, and there we had a public health team of maybe 5 public health nurses for that area. All the medical providers were essentially sent home for a while because we shut down routine operations, and they were not used to backfill the public health response. Difficulties with paying people overtime or providing extra monetary incentives for working the way that they had to work interfered with our ability to get some civilian providers to step up to the extra responsibilities required. So we need to not only man ourselves for the pandemic level, and I know that's impossible, but getting closer to that. But we also need to leverage the technologies. We need to get smarter about being nimble enough to leverage the technologies that can alleviate a lot of the mundane chores that we had people with doctorate and master's degrees doing, that an on-the-shelf or off-the-shelf program could have done for us. And we also need the personnel policies that allow commanders and leaders to be more flexible to be able to put folks in the right place at the right time for the right amount of time. Over.
I'm sorry. Sorry, I was talking on mute. So thanks very much for that, Rodney. One more question did just come in from Charles Brumlick. You mentioned antivirus is the holy grail. Which specific DoD centers lead this effort?
So I believe there's a lot of DoD centers that are involved in the funding of some of this kind of research. Certainly DARPA has an effort, and I don't know specifically if they are doing the antiviral work, but DARPA is involved in funding a lot of pandemic preparedness and prevention work. USAMRIID, United States Army Medical Research Institute of Infectious Diseases, and Walter Reed Army Institute of Research also are involved in developing and testing antivirals to be able to respond to the next epidemic, pandemic, in a more effective, efficient manner. And I may not have hit all of them. I apologize if any of the rest of the panel know of other efforts. Please chime in. Over.
I think he is.
I can think of a non-DoD one. It would be BARDA, but within DoD, I think you probably handle most of it, Rodney.
Well, great. That takes care of all of the question and answer from the audience. So with that, gentlemen, I will extend a very hearty thank you from HDIAC for taking part in this panel discussion. This was kind of new for us to do something this way, but I think it was very well done. So thank you guys all very much. Thank you to everybody who joined in. Again, this will be recorded and we'll post it on our YouTube page within the next day or two. So you can go there to review it if you want to share it out to any of your colleagues. And as always, you can, if you need more information, you can contact HDIAC a couple different ways. Go to the website, hdiac.org, or just email contact@hdiac.org, and somebody will respond to you. But again, thank you all very much. I appreciate it.
Thank you.
Awesome. Thank you.
Thanks, John.